good morning or good evening, wherever you are connected and listening to us. I'm very happy to be here today and replacing the organizer of the ODIN webinar series, our deputy coordinator, Sergio Guillén. I am Giuseppe Fico from Universidad Politécnica de Madrid. I am the technical manager of the ODIN project. We are very, very happy to have this Friday and closing this this working week with a wonderful webinar. Today is going to be, we are going to talk about the Ubiquitous Hospital, and it is my pleasure to leave the floor to one of our partners that is organizing this, one of our partners of the ODIN project that is today organizing this webinar, and is one of our hospital so we are starting this series today with them, and I will leave the floor to Dr. Macarena Torrego. Macarena, the floor is yours for sharing this webinar.
Thank you very much, Giuseppe. I am Macarena Torrego. I am part of the Innovation Unit team, and I have worked for the last 8 years in the Health Research Institute of our hospital, Hospital Clínico San Carlos. Today, we are glad to talk about two current initiatives that we are currently developing in our hospital. They are both framed under the concept of hospital without barriers and putting the patient in the center. Our first presenter will be Cristian Bengoa, who will talk about CARDIORED. It's a current initiative framed within 4 hospitals here in the community of Madrid for the cardiological patients. And afterwards, Arantzazu Álvarez de Arcaya will talk about how new technologies are helping patients to recover quickly by facilitating home care. So, first, Mr. Bengoa has performed a master in leadership and management in health and social care from the University of Leeds. And he has spent he spent 3 years working at the National Health System Confederation. And since 2018, he's the project manager of CARDIORED. And his role is to support the clinicians in the delivery of quality improvement locally and across the whole network. So, Mr. Bengoa, the floor is for you. You can start your presentation.
Thank you, Macarena. Okay, so let's talk about a network of 4 hospitals, not just hospitals as well, 43 primary care centers, and to a slightly lesser extent, the ambulance services of Madrid. So I'm not a doctor. My full-time job is to support clinicians in delivering quality improvement projects across our network. Just a bit of Spanish, cardio means cardiovascular, and red means network. So we're the first network in Madrid that's organized in this way. Very briefly, let's have a look at how Madrid is organized. 32 hospitals, 260 primary care centers or GP surgeries, 6.5 million people living within the region of Madrid, and universal health coverage and no co-payment. And as most health services, at least in Europe, the point of entry is either through A&E, through accident and emergency, or through your primary care physician, who then gives you access to specialist care or acute care, and then takes you home. And so we have this demographic of the aging population. However, the graph of the financial spending does not match how our aging population and how all of these chronic diseases, including cardiovascular care, which is the biggest cause of death in Spain, is not increasing and matching that spending. So this is our population. We have 1 million out of those 6 million who, let's say, we take care of that million people. We've got these 4 hospitals. Each has assigned about 12 to 15 primary care centers. And we like to say we take care of the million hearts. And so how did this start? And this is the, let's say, the step that gave or that established the trust between the professionals, the clinicians, managers, nursing, etc. And so what happened was in 2003, two hospitals came together in the area of cardiology, and they said, hey, how about rather than me, smaller hospital, building the infrastructure and the clinicians to do small cardiovascular cardiology procedures, so either percutaneous coronary intervention or arrhythmias treatments. So rather than having to hire the clinician, create the space, having not only doctors, but nurses and all the support staff, how about you just send me the most expert hands that you have in the complex care hospital? And that's what we did in 2003, and that's what they did in 2003. And clinicians went to the hospital once or twice a week, and then they came back to deliver care at their primary hospital. And that stops patients from having to move across, a relatively large area in a moment of acute care. And to that arrangement, another secondary or intermediate care hospital joined in 2012, and then another in 2017. And so in 2017, we had 4 hospitals working together. And we said, okay, we've got the network established of 4 hospitals. How about we join now with primary care, and we join with the ambulance provider? And so that allows us to say and to work in now not just delivering care, but also the area of prevention. And I think that links rather nicely with this concept of ubiquitous hospital that we're going to be talking about today. And so we've got these one high complexity hospital, 3 intermediate complexity hospitals or secondary care. There's 43 primary care centers out of the 250 and the main ambulance provider. And then we've got what used to be hospitals acting as islands, transformed into hospitals working as a network, sharing professionals, sharing patients, sharing knowledge, to now a fully integrated system of primary care, hospitals, ambulance, working together, not just to deliver care, but to do innovative projects together. And so we've got 2 branches, which I've sort of touched about. We've got one, which is providing the cardiovascular care, and that's sharing, referring patients, that training of 4 hospitals simultaneously, which allows you to grasp the most expert teachers, if you will, of knowledge. And then every week, each of the hospitals presents their cases of the most complex patients to say, what should we do with this patient? And that happens weekly, as does the training, as does referring patients, as does sharing professionals. So we've got this weekly thing that is happening all the time to deliver care across the hospitals. And then we've got the other branch, which is where I'm more involved, which is the quality improvement work across our network. And our projects can be either fixed in one hospital, it can be fixed around 2 hospitals, depending on their interests. It can be all 4 at the same time. It can be one hospital tries it out first, and then the other hospitals join. It can be primary care and 1 hospital, primary care and 2, 1 hospital, all 4 hospitals, primary care and the ambulance provider. And so we're not very specific as to how innovation can come in many sorts of ways. And we do this work in 4 areas, very simply: pathways and processes, population health, and digital transformation and patient experience. So let's look at pathways and processes. And this is something we've known for ages. Now look at the process, suggest an improvement. This is the process for a patient that has a heart attack and he comes into hospital, and how he should leave hospital. And we noticed in this at Clínico San Carlos Hospital, we said, patients are coming on 2 separate occasions when they could just come one. And we saw that with their blood test and their ECG. And we also saw it with their consultation. He said, these patients are coming to our consultation with no need to come together just to take a referral for the tests. Anyways, that's very specific to this project. And then we designed an ideal pathway. And we do this across 4 hospitals. You know, it's unusual, at least in Spain, for more than one hospital to agree on the ideal pathway. And that's something that's that we think is really interesting. And so this is, you know, what we do with atrial fibrillation, and this is the process. I'm not going to stop and dwell on it, but this is the way we think the ideal one should be. And sometimes, you know, we're trying to reach this ideal version across the 4 hospitals. Obviously, we're aware of local specifics. And so this doesn't always apply exactly like we would like. And so the innovation unit at Clínica San Carlos, you know, this is a spectacular piece of work that they did around analyzing with the data that they had available and a bit of artificial intelligence and quite a bit of data mining. They were able to show us, you know, clinicians, management, nursing, how patients are moving across our hospital when maybe our expectations of how they're moving and switching between different units, different consultations, if they're where they're entering from. And that's a really interesting piece of work that they did. And we use that data to do something with them. And this is the bit where we're talking about ubiquitous hospital, you know, population health. And so we've done 2 things here. I'm going to mention one of them now and one of them later. The one now is it's unusual for hospital care to be involved in prevention of, let's say in this case, the flu vaccine. And so we did this huge piece of work 2 years ago where, you know, COVID was huge and people had the fear that COVID would match sort of the flu epidemic. And we did a big vaccination boost among cardiovascular staff in hospital, where for every, as well as primary care, by the way, and primary care and hospital staff who got their flu vaccine, if they belonged to our network, we would give 1 vaccine to children in developing nations through UNICEF. That's an idea we copied from the NHS, from a hospital in the NHS. And, you know, some hospitals reached 100% vaccination rate among their cardiovascular staff. We're doing some stuff on digital transformation, and this is a tool which measures your anticoagulation, which is really important, you know, if you have atrial fibrillation. And so this tool, whilst useful in hospital care, which is where I am physically most of my time, is most useful in primary care because patients, whilst they are maybe diagnosed in hospital, they are then controlled and followed up nearly every 3 weeks, all the time for the rest of their lives. They're going to be controlled in primary care. And so we developed this tool that allows you to see if a patient is within range. That's a very brief explanation. But what's interesting here is, okay, again, hospital has worked with primary care to deliver something that works for the population. And then patient experience, this is a very specific example. This is 4 hospitals, again, 4 wards led by nursing staff, where staff can put their picture on the wall and the objectives of the day and the observations, for example, if they're going to be discharged tomorrow. And that is something we've shown here. And then a bit of a survey suggesting, you know, what could we have done better? And so these are our 4 areas. So I'm going to explain another population health initiative, which is new, it's upcoming. That's why I put a little sticker there. It's an excellent example of ubiquitous hospital, mainly because it's a hospital that's actively involved in population health, 4 hospitals, in fact. Primary care is always keen to receive support if you are responsive to what they're suggesting. And what we're going to do is we're going to screen a random sample of 7,000 people of 50 to 75-year-olds. You know, we're going to be looking at hypertension, we're going to be looking at their cholesterol, we're going to be looking at their diabetes, their smoking habits, their lifestyle, their, you know, their weight and their height, their BMI. and some, let's say, some equity issues, about like they've gone to university or they're having, etc. To understand, this is the question we want to answer, is to understand the real prevalence of cardiovascular risk factors in our population. Not only that, not only do we want to find out if our population is healthy or it isn't healthy, we want to find out, to test if screening a healthy population or not so healthy population is worthwhile. Is it a worthwhile investment? And we're sort of leading in our population that idea. The NHS has done it for a long time. They've been doing it since 2009. They screen for cardiovascular risk factors for people from 40 to 75 years of age. And we do it in lots of other countries, just not for cardiovascular disease, but we do it for colon cancer, we do it for breast cancer. And so what we're trying is we're going to do a shift and say, hey, let's take care of this and see if it's worthwhile. First, let's see if they're as ill as we think or we don't think they are. And second, let's test this idea. And so it's the idea here, I think, for us is whenever we design a project, we're not often thinking as to who is going to lead, who is going to take the step forward. It's really a sort of a mishmash of stakeholders. And because the patient never really cares who's in charge. And so this is a really good example, which we hope we'll be able to deliver by next year for those 7,000 people. Very briefly, these are excellent documents on improving and delivering care across network. The Health Foundation is, the Institute for Healthcare Improvement is fantastic at following and giving a structure for quality improvement projects, even across networks. And some of our documentation and information that, what we have to be good at is not only at being good, but sharing that we're good. And that's all I have to say. I'd be glad to answer any questions if you have any.
Well, I have a question for you, Mr. Bengoa. I want to see, if you see, what is the main innovation or the main adjective you will say that differentiates CARDIORED from other initiatives that are currently being developed here in Spain?
So there's something specific about CARDIORED, which is it was never suggested from the top down. It came from at the beginning, it was 4 heads of service of cardiology who came together and they said, we need to be doing something to unify how we deliver care. And so that gives you a strength when clinicians come together and they say, okay, let's do a bit of work in our hospitals. And then when they've tried that out, they say, okay, let's do a bit of work with primary care. And then over time, you're becoming progressively this network in which people know your interest is improving care for patients. And, and that's really important because you can't just start a network and say, okay, now we all care about the patient, because you've never proved it. So there's never been trust. So you have to build that trust progressively and led by clinicians. This was not a top-down initiative. In fact, we're more than happy for there to be a CARDIORED 2 or 3 or 4, but a population of 1 million is about as good as it can get. If not, it becomes a bit too big to handle.
Thank you very much. I want to remember also the assistants that you can make your questions through the chat. So if you have some questions, you can leave there. And maybe we can go for the second talk of the day. And then afterwards, we can come back and maybe talk again about the different initiatives. Thank you very much, Mr. Bengoa.
Thank you.
So now we will have Doctora Arantzazu Álvarez de Arcaya. She is medical doctor. She specialized in internal medicine with a PhD from Universidad Complutense de Madrid. She's currently the director of the Division of Hospital Medicine in our hospital. And she's also an associate professor of the medicine school in Complutense University of Madrid. She's also the coordinator of the Spanish Society of Internal Medicine, especially for the relationship with the patient. So, Dr. Álvarez de Arcaya, I give you the floor and you can start with your presentation.
for inviting me to talk about something that has really made me think quite a bit. I know little about it, but I will express just my opinions. This is the summary I'm going to follow. And as I was saying, while I thinking how to start the talk, I did a first search about Ubiquitous Hospital, and I find almost 6 million results. And when I did the same in the same Google, the results increased till 21 million of entrants. And well, I started with the definition, what is Ubiquitous Hospital? And I find this when I wanted to share with you that healthcare, ubiquitous healthcare is the healthcare for anyone, anytime and anywhere by removing location, time, and other restraints while increasing both the coverage and the quality of healthcare. Most of the results are related to information systems or data systems collected in electronic registers and monitor systems to detect alerts of vital signs in patients. And also I found the terms U-Hospital and Ubiquitous Health related to monitoring the patients wherever they go, and Ubiquitous Healthcare that refers to the provision of services to improve clinical diagnosis. And this is very interesting. This page is the only one I found that refers to a group of professionals who offer services through a digital platform. They are integrated by an internist, and specialist in pharmaceutical technologies, and another one specialized in critical care. They offer something that I find very interesting, which is the support for caregivers, which is so important for chronic patients and so forgotten. They provide a holistic approach to physical health and mental wellness. And these two also seem of great interest for me. The support, the use of technologies for support, the clinical decision-making, and the ethical aspects of ubiquitous healthcare, which was already proposed in 2007 and today is still not solved. But I wonder, what do patients think? What do they prefer? What do patients need? And have we developed these systems by asking patient first? I don't know. And I'm afraid not. I believe that the Ubiquitous Hospital is caring for patients outside the hospital walls. I recommend this document, Future Hospital, published by Royal College of Physicians in 2013, reedited in 2017, when they draw the interconnection between the professionals, the different health agents, where the borders are thin and movable. So we would have to talk hospital without walls, where the patient is in his house during the post-cure process due to a medical or surgical illness. And the Guardian newspaper says that the future are the hospitals without walls. And I am agree. And with that said, I am going to briefly explain what is hospital medicine. Anyone know what it is? Probably a few people knows. As the Society of Hospital Medicine says, hospitalists are the transformer of the healthcare, the revolutionaries of the patient care. Hospital medicine is a specialty that provides comprehensive care to hospitalized patients. Hospitalists treat complex patients and patients with high burden of disease. We facilitate the continuity of care and improve the performance of the organizations. And mainly, the hospitalists are physicians, but there are also non-physicians practitioners as nurses. The base of their attention is co-management. Hospitalists share responsibility of care for the inpatient care with surgeons and specialists. They visit every day patients and respond to all patients' needs. In addition, they make hospitals safer by implementing safe protocols and practices and improve the patient's outcomes. Hospitalists facilitate the collaboration and communications between professionals involved in patients' care. Hospitalists support a safe transition within the hospital, but also from the hospital to the patient's home. And we make judicious use of the resources. We practice high-value medicine as a term defined by Michael Porter, because we seek to achieve the outcomes that matter to patients with being more efficient. And we do this by implementing clinical guidelines, optimizing antibiotic use, holding interdisciplinary rounds, reducing unnecessary tests, and being more efficient and improving the patient satisfaction. And what is the hospitalist model like in Hospital Clínico San Carlos? Well, internist, a hospitalist internist is integrated into the surgical department, full-time job. We team up, we collaborate with professionals, but also with patients. We make shared decisions. We make shared decisions in interdisciplinary rounds, and also with the patients. In addition, due to our holistic vision, we coordinate the care that the patient needs. Unlike the United States, we provide patient care outside the hospital. This is quite different from states. In short, hospital medicine is a new organizational model, a model care for patients with high needs wherever they work. We work as a team with patients and with other professionals. Hospital medicine in Hospital Clínico San Carlos was created in 2010. I started working with general and digestive surgeons, urologists, and oncologists. In 2011, a case management nurse was incorporated. In 2013, we implemented quality management system and obtained the certification according to the UNI ISO 9001:2015 standard. Little by little, we have been working with other surgical departments and new professionals have been incorporated. We do interdisciplinary sessions also with social workers. In 2017, we began to teach at the School of Medicine of the Complutense University of Madrid. And now, currently, we are 4 physicians, 1 management nurse, and 1 administrative staff. We serve patients of medical and surgical specialties at the hospitals, mostly surgical patients. And since 2020, we have been doing telemedicines because we try to make life easier for our patients, their families, and their caregivers, practicing medicine centered on the person with a holistic perspective in which we include social factors which are so decisive in the evolution of the diseases. And our mission is to gain that the patients gain health, reduce the burden of disease, and that organizations and the resources adapt to patients and their caregivers, and not the other way around. And we do it by asking our patients what they need. They need an holistic care, social needs, diagnostic, and of course, therapy procedures, where they prefer to be treated, where are they, at hospital, at home, at outpatients ward, and how we can help them, patients, we can help the family and their caregivers. And when have you problems nowadays with the job, we have problems to family, you are at the same time the caregiver of your mother or your father and your children. And of course, we measure our results, but we measure our results from the perspective of the patients, the caregivers, the managers, the professionals, and the community. And in this scenario, the question is, how can we incorporate the use of technologies into our high-risk patient care model through the whole care process, a continuity of medical care through a surgical episode for high-risk patients, through the preoperative evaluation, in the immediate postoperative evaluation at hospital, or postoperative follow-up as indicated. A process that has different boxes where different professionals intervene in each of them in order to maintain continuity of care regardless of where the patient is located. Do you agree with me that we had a true technological revolution in the last century? There are already assist robots for detecting alerts in critical patients and initiating the pertinent care. And we did a status analysis for our program to see where we could improve our process using technology. And we saw that we have to answer our process we saw we had to improve our water, ensuring the safety continuity of care and an environment without walls. We had to be able to move the hospital to where the patients needed and know our results from this new care modality. And we believe that if we could apply monitoring devices, we could make the process more secure. So we spoke with our colleagues from emergency room, cardiac surgery, and cardiovascular institute, and from this new care modality. And we believe that if we could apply monitoring devices during the post-discharge period, like cardio system, we can detect warning signs and avoid complications in post-surgery period when the patient is already at home. We can monitor the respiratory rate, we can know heart rate, we can know the temperature, we can know the blood pressure, the weight, and so on. So we could make decisions with clinical data. And our telehospital stage had begun. We were achieving a liquid Ubiquitous hospital. We moved to where the patient also needs us, his house. And with this, we reduce the readmissions and frequently the emergency room. And the patients felt safer and calmer, because providing specialized and safer care at home improves patient recovery by improving sleep quality, sleep and mobility, reducing the incidence of the delirium, the use of sedative medications, and reduce the fall rates. At the same time, a greater involvement of the patient is achieved, and the satisfaction of the professionals increases. The future is transform the patient's home into a hospital, a virtual hospital. The incorporation of control and clinical monitoring devices allows specialized and high quality care to be provided. And this is important for an increasingly elderly and disabled population. And our patients seem to be happy. So the question is now, is a humanistic medicine possible with the use of technologies? I leave that for discussion at the next conference of the Spanish Society of Internal Medicine and Patients that we will celebrate on October 5th in Madrid, and you are all invited. Thank you very much.
Thank you very much, Doctora Álvarez Arcaya, for your presentation. It has been very interesting. I think that hospital medicine is a little known specialty, but with a relevant role. And I find especially interest the inclusion of the social dimension also of the patient in your pathway. So congratulations. I don't know if there's any question on the floor.
Thank you, Macarena. If I may make a question? Yeah. So thanks a lot to you both for this great presentation. My question is for you, Arantxa, but also Christian may comment, because it's somehow related with what I'm going to say. In the ODIN project, we are trying to use to see how these technologies of the future, we call them key enabling technologies, like Internet of Things, robotics, artificial intelligence, in this context of digital transformation, can enable the definition of, and implementation of new processes for improving outcomes. So in your regard, in the ODIN project, but also that's my question to you, we have identified the importance of understanding the change management perspective. So I would like to understand also from your side, since you are talking about innovative processes, what is your experience on how make this innovation really happen, and how do you involve the professionals, the patients, and any other agent or stakeholders in this aspect?
I'll go first if you'd like.
Yes.
So very briefly, I think, so we often work with, people that come from the outside, and they say, we have this solution for you. And that sometimes doesn't work very well, because you have to make sure that you know what the problem is. And so the order in which things should be presented to stakeholders, which could be a whole array of stakeholders, is that the clinician designs, or the clinicians in this team design the process, and then the solution sticks into that process, not the other way around. And I think that sometimes it's natural to know that your solution is perfect for this problem, but the clinician or the team involved in the hospital or primary care hasn't reached that point of understanding. So maybe if you take a step back and say, let's start from the beginning, and let's design a process with the clinicians, and the clinician then finds out the problem that you already know exists, and then you have your solution. That would be my initial thought on that.
Thank you.
Yes, I agree with Christian. Yes, I think the technologies are a tool that we can use to make safer process. And I said in my presentation, I worked on hospital at home for 6 years, and I see how can we help our patients using the technologies. In that time, we haven't the CARDIORED system, so we have to make decisions with very rude tools, And the question is, how can we incorporate these technologies? No? Because I see around me sometimes that use some of them instead of professional, and I think that is our own idea. I think that we have to use them to help us to improve our process. So in the same time, in the same way I use my phonendo, I use in this case, I use the cardio system to improve what I perceive when I visit a patient. And it's the same if there is in the hospital that we could use it, or it is at home. I think the big chance is to advance care at home using these technologies.
Thank you. Thank you.
I think that Ignacio Martinez has a question also.
Want to ask about the cost of treatment at home.
Ignacio, do you want to ask it directly or? Sorry, Anna.
I answer that question, would you like?
Yeah.
Right?
Yes.
Okay.
There is also another question afterwards.
Okay. Yes. In Madrid, the stay at home is about 250 euros till 300 euros. You know, this is a mean price. This is nowadays in Madrid, right?
Okay, it's a good reference to compare with the hospitalization.
Yes, Macarena, if I may, there is another question from the chat. What kind of patients are part of the hospital at home program?
Sorry, what kind of patients?
Yeah, are part of the program.
I don't see the question, sorry. Yes. Oh,
yeah.
Well, I always say we can treat almost all patients. The question is, we have to make a good selection of it and to train the caregivers, because it's very important to support the caregivers, because at home there are no nurses full-time, so the family or the caregivers have to do the role of the nurses and like a hospital, you know. And we can treat acute diseases like infections and so on, and of course we can treat post-acute care patients. This is usually to finish the convalescence at home of surgical patients or any kind of diseases. And also we can treat disabled patients, you know, disabled. It's very difficult for elderly people or disabled people to transfer to hospital because of the limits of their mobility. So this is a very big opportunity to use the devices at home to check all the population with disabilities. And let me see another thing about the question before. The treatment at home is 250 euros more or less, and the stay one stay at hospital in internal medicine is about 600-700 euros. And surgical patients, like for example maxillofacial patients, the stay is 1,900 euros per day, right?
Yeah. The comparison is...
Yeah, it's a very big difference.
I see that we have another question in the chat. This is for Christian. What is... was it hospital care or was it primary care that suggested and is leading your screening study? What was the initiative coming from?
So this is a good question, because it proves the example of how hospital and primary care starts to not matter anymore when you work together so long. So the idea started in the hospital from a clinician who says, I don't know how sick my population is. And it comes from a thought of, okay, I see the worst of the worst in the hospital, but if I pull back, I don't know what my population is like. And so the idea started in hospital, and in fact, we're still leading the work, the brunt of the work of delivering the project, but we're working under the umbrella of primary care, and it's primary care that's sort of serving as our excuse to move forward and say, hey, primary care said we could do this when we face the different obstacles that we face in the system. So the idea started in the hospital, but the data is going to be registered in a primary care. It's the information systems of primary care that's going to be involved in the project, but the lead is a clinician from the hospital, and the support is coming from the hospital, and it's really a mixed match of different things.
Well, the good thing is that it's a multidisciplinary team, no, that you are working on. So that is the point of the program. We also have another question. If I think it's also, I don't know if it's for you or for Arantxa, but anyway, do you have some satisfaction questionnaire or some specific questionnaire to collect the patient's opinion and satisfaction with the program? And what are the current answers or background from the patient?
You want to go first?
Yes.
Oh, okay, I'll go first. That's fine. Yeah. So we did in hospital care. We put a QR code as well as a paper survey based on the friends and family test, which is a survey which actually is answered in the UK health system over 1 million times every month. So it's a survey that is it's used all across the country for primary care, and it's a very simple question. It's saying, would you recommend this service to a friend or family who needed similar treatment? And actually, I'm because I read the question just before you asked it, I'm going to share my screen very quickly. And so this is, how we have it on our wards, and we can see it there. And so the thing is, when you ask people who you've just saved their life, if they would recommend a unit, they tend to say they're okay with it. So it's easy to get good results to this question. But the answer goes from very likely to very unlikely. Red is very likely here in Spanish. And so most people are very likely to recommend one of the 4 wards belonging to our network. This is hospital care. And then we did I was talking about how we did the whiteboards and a few other things. And as a result of the whiteboards, patients had answered more positively to, would you recommend this unit to a friend or family? And then there's a few quality improvement areas where you can always say, hey, my food wasn't good, or the window was open, or I was cold. And the thing is, the nurse supervisor gets the results in an email every Friday. Here we have an example, and it shows if there's a deviation. And that's really interesting for a nurse ward to every week get results, anonymous results from her patients, and see, hey, why have my patients this week been reporting worse results? And the important area here is the automatic email sending, not a proactive search of results. It's the nurse supervisor gets the results in her inbox, it appears on her screen, and then that causes for tiny quality improvement areas, which maybe work. So this is one of the specific things we've done. We've done other things, but I think this is a very digital one and a very automatic one. I don't know, go ahead, yeah.
Yes, we do, I don't know what this, we do, it's the same. We ask patients, we ask patients at the discharge, the moment, the discharge, and we ask about the treatment, the information, the coordination, and so on. And they value the coordination and the information. And they also value the kindly. You know, I put a slide with the qualitative results, no?
Yes.
And it's very interesting, no? It's very interesting. And now we are working in a new survey for the telehospital model. No? We're working with a qualitative view, you know, but I am working now on it.
So really interesting. Thank you very much, to both of you, for your answers and your values, your valuable experience.
Perfect. Thank you.
Thank you.
Giuseppe, do you want to say something else? Someone has anything to ask or to comment?
No, I see that there are no further questions. We are perfect on time. So if you want me to say some conclusive words, let me thank to you, Macarena, for having chaired this session, and Christian and Arantxa. It has been a fantastic discussion, and I hope stimulating many other questions and ideas. For sure, in our ODIN project, it will be done. And so let me thank you, and let me tell you that soon we are going to communicate the new some news about the next webinar. We are going to talk about digital platforms, so the other way around, and we will very soon communicate this news. So thank you very much, and I wish you all a pleasant weekend.
Thank you.
The same to you.
Bye.
Thank you.
Thank you very much to all the attendees.